aging in women living with HIV. So welcome, Dr. Barbara, and thank you so much for preparing to give us this talk. We're really looking forward to hearing more about HIV and aging in women. Thank you.
Thank you so much for this comprehensive presentation. Let me know if you can hear me. Maybe you can just send thumbs so I know that I'm audible.
You're audible.
Can you hear me? Yes,
Yes,
the
we
thumbs are
can.
coming. So let me now try to share that usually is my weakness, being able to share the screen. So let's see. Can you see a PowerPoint presentation?
Yes, we can. Yeah, maybe just put it on slideshow.
Okay, perfect. Um, uh, yes, I did. Can you confirm?
It's not yet on slideshow.
I think yes.
Now it
Uh,
is.
um, okay, thank you. Thank you so much. So because I'm on slideshow, I may not see other things, comments or questions, but if there is anything, maybe you lose me, just let me know using the terms or something so that I know. Again, thank you for this wonderful presentation, introduction, and for giving me the opportunity of giving this presentation. Now, this presentation was given 2 weeks ago at the workshop that was held in Nairobi about HIV and women in Africa. So that is why it is really narrowed down on women, and we really try to look at the data on Africa. Of course, even men are included in this conversation, but this presentation focus on women because of this reason, and there are also reasons why we should also emphasize some aspects on women. Maybe another thing I want to say up front is that I'm originally actually an infectious diseases specialist. And so, as it was said in the presentation, this is also something I'm learning myself on how to look into aging and non-communicable diseases in people living with HIV. And so I tried to learn through my fellowship, but also during my fellowship, I had the opportunity of putting together a team of trainees that looked at different aspects within a big cohort. And so some of the work that I'm going to present, it's really teamwork from me, yes, but also from my trainees, and I will acknowledge them. Let me really now dive into rightly said, the achievement really of the goals 90 90 90 or now 95 95 95 is what has led now to what we are seeing, and so our aging population, because first of all, we had a decrease in opportunistic infection, and so a decrease in mortality, and therefore people are aging. Then also we need to look at the aspect that as people age, they are also exposed for longer time to HIV, but also to antiretroviral treatment. And that has really caused also surfacing of non-communicable diseases among this population of interest. And for the same reason, increase on aging and increase in exposure of HIV, we also have the surfacing of geriatric syndromes. There's also a smaller part of people that are actually diagnosed with HIV when they're already old. So there are not many. It's estimated that it's 4% of the new infection in sub-Saharan Africa is among all the adults. But we also have to consider that all the adults are still sexually active, so we should not shy away from asking their sexual history and test them if needed. But so all in all, this really says to us, I'm sorry, I can't see what I'm sharing my side. Give me a second. Can you still see my slides? I can't see my own slides. Uh, I don't know what I did. Um, you see the slide, but I don't see them. Um, Let me just continue as I try to reshare. Okay. Okay. All right. So what we are really trying to look really in this and focus this presentation is how we can find a way, which now is a priority, to promote healthy aging in people living with HIV. Healthy aging will be defined as maintaining the functional, physical, psychological, and cognitive ability to enable the well-being and also independency. And so, in my view, this could also be considered a kind of fourth 90 or 95 target for other people living with HIV. So let's define what it is old. So usually in people with HIV, we consider the cutoff of 50 years, so younger than the general population. And the reason for this cutoff is because after 50, there is an increased risk of mortality, which is threefold as compared to people living with HIV that are less than 30. There is also risk of comorbidities and polypharmacy, although polypharmacy is not very common in our setting. There is also an increased risk of geriatric syndromes, which start appearing at around 50 years, so earlier than in the general population. Um, Also, I'll touch briefly on that at the end, but menopause seems to occur earlier in women with HIV, and there is a higher proportion of women who experience early menopause. So these are all the reasons why we would like to have this cutoff at 50 when we talk about older people living with HIV. So I just wanted to show this because some people have the perception that we don't have older people with HIV in Africa. But the truth is that if you look at this slide, this here in the upper left shows you the absolute number of people with HIV over 50. The blue line are high income countries. And the orange curve here is the projection in low and middle income countries. So you see that all these people are actually in our countries. And when you look down at the graph with the blue bars, you can actually see that the highest number in the world of older people living with HIV 50 and over is actually Eastern and Southern Africa. So these were estimated to be around 3 millions in 2020, and probably there are many more as we speak, 5 years later. I also wanted to show here on this graph on the right, this is data from Uganda, but I believe other countries in East Africa, I don't know the epidemiology of Kenya, but may face similar trends. So what we have in Uganda from the last survey population in 2022, I think it was, is that actually the highest prevalence both in men and women of HIV is in the population 45-49 and 50-54. So these are really where the HIV prevalence is highest of all ages. And as you can see, women, at least in Uganda, up to the age of 60 is actually the population where the prevalence is always higher. So again, this is why we are emphasizing talking about HIV in women, older women. So here I just want to touch base briefly what are the health concerns in older people, and then looking at also older people who are women and older people with HIV. So generally, even without being a woman or with HIV, what happens is that there are some non-modifiable factors like age, sex, and human race that can predispose to non-communicable diseases. And then there are also some modifiable factors that can predispose to non-communicable diseases. The same goes also for geriatric syndromes. So all these risk factors can predispose a person to geriatric to be at risk of geriatric syndromes. Both geriatric syndromes and non-communicable diseases can, for example, put people at risk of polypharmacy. Now, what happens when someone has also HIV and co-infections. So people with HIV, so HIV itself is a risk factor for one, non-communicable diseases, two, geriatric syndrome, three, polypharmacy. So you can see that this is adding up to already baseline risk factors that are present in the general population. Now, if we add that you are a woman, especially because of issues of early menopause, but it's also believed that there is somehow inflammation, ongoing inflammation in women is higher than in men, even without HIV. The same can predispose again to non-communicable diseases, geriatric syndromes. Sometimes polypharmacy is, for example, women receive treatment for symptoms of early menopause. So you can see here how really there is a converging factors that are enhanced by having HIV, but also being a woman. Now, this slide I didn't present in at the workshop because I didn't have time. But since this is a kind of research webinar, I just want to talk about this because I always find very difficult when I look at the literature and even the data we have, and you start to do comparison. Very difficult to find out if we have an ideal control group. So I will try to take you through this. To explain why I think that are serious difficulties in finding an ideal control group when we're talking about people aging with HIV and particularly women. So when you look at data from income countries, this is this quadrant, I hope you can see, and the individual characteristics. So when you look at data from income countries, they have serious of famous aging cohort in the Netherlands. You can see that only 11% are female. So their data usually, when they do publish, they cannot really put sex as a risk factor because the numbers are too low. Now, when we also look at the females in high income countries, apart from the numbers, these populations, so female, if you look at comparison of female without HIV and female with HIV, also is very difficult to make comparisons because women with HIV in high income countries, they have a lot, you can find a lot of confounders. Usually, these women are not comparable. They have, for example, history of use of drugs, they are heavy smokers, they are heavy drinkers, they're usually underweight. So they are actually different. So it's very difficult to find out if some of their outcomes are a result of having HIV or all these other life kind of lifestyle and habits they have. Now, when you go to sub-Saharan Africa, this is our cohort, it's called HASA, and you can see that we can actually compare male and female because we have almost 50-50. So within people with HIV, we have a good representation, and then we can make really gender comparisons. I also think that, at least I talk for Uganda, that the female population with HIV and without HIV are actually comparable. In Uganda, the HIV epidemic is very democratic. It's everywhere, in each social class, in each type the women particularly bad habits. So you actually can compare those with and without HIV without worrying too much about so many other confounders. Now, when we look at health system, sometimes again it's very difficult to compare outcomes in population with and without HIV because often in high income countries, HIV epidemic is concentrated in some marginalized population, especially if you think about the US. And so these populations are also underserved. So the negative outcomes we see in people with HIV are due to the fact that they have HIV, or so their characteristics, or they are related to the fact that the access to care is actually not equal. And so that also poses a big problem in trying to understand what is doing what. Now, when we go to sub-Saharan Africa, it becomes in a paradoxic way equally difficult because there is really now data from some countries. I'm not talking you from, there are papers from Uganda and from South Africa that actually show. First of all, they come to the clinic and they receive regular counseling on healthy habits. You come to the clinic and someone measure your blood step that is a very for example, in where
Dr. Barbara, I think we lost you. We can't hear you clearly.
you lost me. Can you hear me
I
now?
think yes, we can hear you now. You were talking about comparing the control groups, the challenges
I
of a control group in in
yeah,
sub-Saharan Africa.
I think I was on the last um because I saw myself going off. So I think I was here. So that people with HIV may actually have better, not better outcomes, but the fact that they benefit from some integrated services may actually counterbalance their HIV related risk factors. And for example, there is data from some countries like Uganda, South Africa, that shows that quality of life in people in older, I'm talking about old people, in older people living with HIV is better than people without because they have some access to care, they have some peer networks, and so on. And so again, it is very difficult to here to districate what is doing what. You know, when you look at some outcomes. Data from South Africa also shows that older people with HIV has better control of hypertension as compared to older people without, because they go every month to the clinic. And so someone check their blood pressure, tell them to take the drugs and so on. So again, even in Sub-Saharan Africa, we may not have control groups that are exactly comparable. Okay, now I wanted to briefly talk about why people with HIV are at a higher risk of non-communicable diseases. So people with HIV has a threefold risk of non-communicable diseases, and it really all boils down to chronic inflammation. This chronic inflammation, you can see really on the left side, starts really at time of then acute phase. So during the acute phases, there is some disruption even at the gut level with translocation of microbial translocation. At the same time, you have HIV that is replicating in the bloodstream, and all of that causes really immune activation. And this starts, as I said, very early. Then it becomes sustained systemic inflammation during the chronic phase, and that eventually can result in uh, tissue damage and organ dysfunctions. So this is the main reason. Added for would be the sequelae of opportunistic infections, for example, tuberculosis. We also know some of the antiretroviral treatment can cause non-communicable diseases like tenofovir and renal toxicity. Then there is also an increased risk associated now with aging. And then, of course, there are also other factors that are common to the general population: age, gender, family history, urbanization, overweight, obesity, and physical inactivity. So, as I said, I'm going to concentrate on Sub-Saharan Africa. This is a systematic review that was conducted in the countries that are now showed on the map. And they managed to actually pull data. And this is not on older people, it's generally in the people living with HIV. And this really shows that we have prevalence of a lot of non-communicable diseases. Look at hypertension around 20%, depression at around 30, overweight 30%. In Uganda, 20 years ago, AIDS used to be called slim disease because everybody was losing weight, and now we actually have obesity in this population. You also have, for example, metabolic syndrome over 20%. So you can see non-communicable diseases in this population are becoming very prevalent in on our continent. I didn't want to show you the data that is here in this box, but it's a very nice study. If you can have time to go and look at it, it's data for high income countries, which really shows that the prevalence of non-communicable diseases is higher in people living with HIV of all age brackets. And the biggest difference, again, as we start seeing in people over 50. When they looked at the art era with the it's a study that starts in the 90s. So when they really looked at the most recent years, when we really have highly effective antiretroviral treatment, this burden is less because, as I said, a big component of this burden is that inflammation. However, is still higher in the people living with HIV as compared to people without HIV. I mentioned already that we could have some problems that we have with the current regimen and non-communicable diseases. So again, this one is a review, the one on the left, about renal function associated with tenofovir. And in this study, they really observed significant renal function decline associated with tenofovir. And this was people at higher risk are those with pre-existing disease and those of advanced age. Does it plateau? Do we need to switch people? After switching, do they reverse? There is really no data. So this is really an area for research. On the right side, this is a study from our cohort published by one of our trainees, where she compared really renal function of people without HIV and people with HIV over 60. And you can see that in people with HIV, GFR is significantly lower as compared to people without HIV. Now we are still looking at art and NCDs, and we are going to move to osteoporosis and fracture risk. So again, there are some factors that are not HIV related, for example, ethnicity. In this case, actually, white ethnicity is the one at highest risk, not black. But still, women are higher risk than men. Then, of course, there is the genes. We have advanced aging, tobacco and alcohol use, generally low BMI and malnutrition. Now, HIV itself is actually a risk factor for osteoporosis, so the infection, and also the use of certain art, and we know very well about tenofovir. So all in all, what we know is that generally osteoporosis is 3 times more frequent in people living with HIV. The risk of fractures increases 10 years earlier in people living with HIV. The majority of the bone loss, again, interestingly, occurs early during the viral replication, and during the immune reconstitution shortly after the start of ART. ART can effectively control HIV replication, so it can reverse this, but again, people on tenofovir may be at high risk because tenofovir actually results in decreased bone formation and also increased bone reabsorption. And so while art can help in lowering the inflammation, we have drugs that are not gentle to the bone. Now, art and weight gain. I just want you to look briefly at this study up here on the right. This was a meta-analysis actually that was done some years ago, and it included people on antiretroviral treatment, like any type of an antiretroviral treatment. So you can see that even before the introduction of dolutegravir, generally speaking, Black female is the population that tend to put on most of the weight, regardless of the treatment that they are started with. So that it's the population at highest risk. Now, when you look at here down, this is a study that I'm sure you may know from South Africa. There is now data up to 144 weeks. And this is the, sorry, this is the advanced study. And so there is also data for male. Male have similar trend, but the weight gain is not so high as compared to women. So I decided just to plot the graphs for women. So you can see that both in terms of percentages on the left, weight gain percentage and absolute weight percentage on the right. The group that put on most weight is the group that is on dolutegravir, particularly when dolutegravir is given with TAF. Now, TAF would have been, apart from the fact that it's not available and expensive, but would have been a sort of a solution to TDF because it is less toxic than tenofovir. However, as you can see, there is a substantial increase on weight. Now, the data of that is presented here also is not just about getting bigger. That would not be the real issue. The problem is that they have now started seeing after 3 years of follow-up, that this is also associated with developing metabolic syndrome. So it's not a matter of just putting on weight. It's really a matter of getting NCTs. I'm going now to shift to geriatric syndromes. So geriatric syndromes are health conditions that cross organ system and disciplines in all the population. They are usually multifactorial and they also share risk factor and mechanism. Now, if you go and you look at the figure that is at the bottom, some of these risk factors are age, cognitive and functional impairment, the presence of non-communicable diseases, and also reduced mobility. So all of these can actually lead to risk factors and can lead to the development of geriatric syndromes. Geriatric syndromes, these are examples. They are mostly those really. Incontinence, falls, delirium, functional decline, and frailty is here because for me is really the major geriatric syndrome, and in turn can actually worsen all the other geriatric syndromes. They actually worsen each other. It's a kind of spiral. When you enter in there, frailty worsens, for example, falls, but then if you fall, you become more frail, and so you enter really in that loop. Now, geriatric syndromes lead to negative outcomes, particularly dependence, disability, hospitalization, and death. Comprehensive geriatric assessment is the systematic, multidimensional process of determining the medical, psychological, functional, and social needs of all the adults. It requires multidisciplinary expertise, and really the aim of this assessment is to come up with the individual plan for people, and also to kind of estimating prognosis, and really see, try to predict, what are the benefit or the adverse treatment responses of an older person. So, as I said, I'm going to focus on frailty rather than all the other geriatric syndrome, but there's a syndrome of physiological decline in late life. which is characterized by vulnerability to adverse health outcomes. So basically, frail older people are less able to adapt to stressors, such as an acute illness or trauma. So let's say you are young, you have an accident or malaria, anything, and then you're back to work. When you're old, doesn't happen like that. That's frail. That's what this frailty is about. It's you're not able to go back to your what you were before. Or it takes much longer for you to go back to your health status, before that event. Is often defined by using five criteria: shrinking, so losing weight; weakness, low energy; slowness, being slow; and low physical activity. And actually, geriatricians think that frailty and functional impairment predict better survival than comorbidities. So you can predict better how long someone would survive or not, or be able to be, for example, independent, looking at frailty rather than looking at the fact that this person has hypertension, for example, or diabetes. Now, female sex HIV out. This shows why it's really relevant that we start talking about frailty as a geriatric syndrome in African population, with emphasis on women. This is a busy slide, and I don't think I would like to take you through all of this, but just to show you the path that leads to frailty. So there are some underlying factors, pathways, and so on. Now, when you look at underlying factors, these underlying factors that are showed in those in this here on this column, they are general, so they are also in the general population. However, there are some that are really enhanced on people with HIV infection, people who are antiretroviral treatment, and people who are female. The pink in this slide is not a mistake. You remember I was giving a presentation on African women. So wherever you see pink is because that in women is plus plus, is more than in men. Okay. So when you look at underlying factor, you can see that all of these factors, all of them really are enhanced in people with HIV. So you can also have them without HIV, but when you have HIV, these are plus. There are more. Then, if you look at the one pink, is because in women there are more than in men. So, of course, obstetric history, physical activity is usually lower in women, social support is usually lower, and also mental disorders are higher. When you look at pathways, again, these are happening for the general population, for people with HIV. In women, immune activation is more, and also neuroendocrine dysregulation is more. All of these can actually result in these pathophysiological events like insulin resistance, anorexia, lipodystrophy, and again, enhancing we have sarcopenia and osteoporosis. Clinical findings, these five criteria already we talked in a couple of slides ago. Now, there are a lot of studies, not a lot, but there is studies out there. I'm going to focus on Africa. So studies in sub-Saharan Africa, there are not so many. And the problem is also that there's so big variation in the way frailty is measured, which age group. So you find all sorts of prevalence. They listed some studies there, but and so on. But some things that come up quite, in every study is that some factors are the same: age, female sex, low education, living alone, low BMI, depression, and low CD4 count. So again, keep this in mind. So far that I know, there is no longitudinal data. Even our cohort data was followed up to 3 years, but we have not even looked at the data. So what is the trajectory of people with frailty or people with pre-frailty? How fast they become frail and so on. This again is from one of our trainees. It was published and it looks at the sex differences in older people living with HIV in Uganda. So what we found, let me focus on the differences and the significant ones maybe. Let's go here on the BMI. We find that women, actually more women are obese as compared to men. We also found that women, older, we're talking, sorry, I didn't specify. These are people that are 60 and above. So we also found women have less money, they are poorer, women have more than one NCDs as compared to men. We found that we have more women that are frail than men. We actually found uh, more women with cognitive impairment as compared to men. More women fall in the previous year, and they have more geriatric syndromes. So you can see they are really more at risk than men, pretty much for everything. Okay, now I'm going to project 3 slides on menopause. These slides were not in the talk I gave in Nairobi 2 weeks ago because there was an entire session. I'm not an expert, so it's a very short review of what you know. I thought this presentation would have been not complete without mentioning something. If we are talking about all the women with HIV, if I was not talking at all about menopause, but I'm going to say ahead, I'm not an expert. So this is just to remind us transition to menopause usually lasts about 7 years. Normally divide the menopause, the transition in early menopause, late menopause, and then post-menopause. So what happens here in this early and late menopause is really like a kind of hormonal storm, where what you have in very simple words is that your ovaries don't produce enough estrogen. So your brain starts increasing the production of FSH because it's like, okay, we need more estrogens. And so because of this increase, temporarily, there is an increase in estrogens that are produced. But then again, because the ovaries are aging and dying, eventually they go down again, and then the brain again registers. This is all during these 7 years. It's a continuous thing. And so then your brain again tries to send another signal to your ovaries to produce more estrogens. So the ovaries again will try. And so it's all this fluctuation that really cause all the symptoms. I really simplified that, but I think it's how people really can understand it, can understand why there are really these imbalances that go on for years until basically the last oocyte in the ovary dies, and then there is no estrogen that can be produced anymore, and that's actually when things start getting better because all these symptoms go away. So these are the symptoms. Again, I'm not going to go through those. There are also a scale to look at symptoms, is the AMRS scale, where you can ask about all these symptoms, and women would rate the severity of these. And so that is used usually for follow-up of women that are in menopause. So what do we know about HIV? So what we know is that probably it should. So the average of menopause is lower than the general population. There is an increased risk of experiencing symptoms by 25-60% as compared to women without HIV, especially psychological complaints, reduced concentration of flashes, and reduced sexual interest. Uh, and these symptoms seems also to be more accentuated in women with HIV. And women with HIV are also at risk of early and premature menopause. So again, the question is this HIV or there are other lifestyle factors? So there are a lot of confounders and other factors that may lead to early menopause. And these are low weight, ethnicity, smoking, substance use, low socioeconomic status, low CD4 count, and high viral load. So again, as I mentioned at the beginning, that's the problem with the control group. A lot of women in these settings are of low weight. They smoke, they use substances, they're from low socioeconomic status. So is it this that African studies can actually show some can actually throw some more light into this issue of menopause because we have less of those confounders. The good news is that seems that menopausal status itself does not influence response as if you're taking well the drugs. So there is not, for example, a slow immune response because you are going through menopause. We need to consider though that maybe some women because of all these symptoms there is also a symptom that is really called like mental fog may start forgetting taking the drugs or they get really distressed and so they may have low adherence. So that's something to monitor, adherence in women who are going through menopause. And then there should be like some art choice consideration. Unfortunately, in our setting, as you know, one size fits all. So we can't really tailor antiretroviral treatment. But ideally, if you're in a setting with the choice of drug, you may decide to leave out tenofovir because early menopause predisposed to osteoporosis. You may need to find out if there are drugs that do not cause increase in lipids. In our settings, unfortunately, we don't have this luxury. This is a study I found from Zimbabwe. So, as I said, most of the studies are from North American, European settings, but this preliminary study from Zimbabwe actually shows that women with HIV, these are the black bars, have really a higher prevalence of symptoms as compared to those without for most of the symptoms in the gray. I know it's not very well visible, but that's the way it was on the paper. But if you really look, apart from body temperature disturbance, all the other symptoms are more frequent in women with HIV. Another thing, CVD, and sorry for the typo, is stroke risk. These are study again, they are study from the Western settings where they look specifically at women and risk of cardiovascular diseases and stroke. And there are small studies because as explained, often female participants, but it seems that there is an increased risk for cardiovascular diseases and strokes in women living with HIV compared to women without. And this differences risk, it really seems is higher in women than in men. And the reason again, it's thought to be because of this early menopause issue. This is preliminary data. We really cannot draw total conclusions. Again, I think studying this in our African population would actually shed more light to see if this is true, that especially in the older age, the difference between CVD and stroke are higher in women as compared to men when we compare with the population without HIV. So these are just jotted down some research points that we may have if we want to look at menopause. I think this is a big area and the studied everywhere, but especially here. So can we characterize menopause in African women? When does it occur? What are the symptoms? Uh, be aware that menopause is a retrospective diagnosis. What does that mean? You can say someone is on menopause only when it is 12 months after the last period. So people go through menopause and they realize when they've already passed the premenopause phase, that is the one that is symptomatic. So we really need to start screening people early for symptoms, probably at the beginning of their 40s. And to determine which age people go in menopause, you need to follow them up systematically because then there are recall biases. Is it culturally accepted to talk about menopause in African settings? Even in high income settings, some women feel really embarrassed talking about this. Can we actually talk about this to our women? Would be interested, in us asking them some things. Some, things we ask about, it's really like hot flashes, but you also ask because of symptoms of menopause, something like vaginal dryness. You ask them about if they have sexual appetite. So would they actually be happy to respond to this question? Integrated service in Africa stop when someone stops having kids. But isn't menopause part of sexual reproductive services? Why do we stop there? Why do we stop to look after women when they stop giving birth to kids? So that's another thing for places that have integrated services. Hormonal replacement, I said before, I'm not an expert. There are really two school of thoughts, and then there are probably people in between. So there are people who emphasize on the risks. There is increase in breast cancer risk. There is risk of non-compliance, cost. There is an increased risk in cardiovascular disease, which is already increasing women living with HIV, and benefits. Definitely, there is an improvement of symptoms, and there is also reduced osteoporosis later in life, and so of hip fracture. So what do we do? As I said, I'm not going to say what I think because I don't think much, but I heard one speaker saying that, which I think makes a lot of sense. Doses of hormonal replacement, if they're available, should be lowest as possible, and also shortest possible time, and started also as soon as possible. Because if you start 5 years later, someone is already been in menopause for 5 years. There is no benefit really. So that's why you have to catch people when they are actually in their pre-menopause period. Can we test non-medicalized low-cost intervention? Hormonal replacement is not going to be available for free. So can we explore? Even sometimes I'm thinking peer groups, women being able to talk about what they're going through may actually help them psychologically to know that what they're going through is normal. So maybe just something like that can help. Should we also screen women earlier for geriatric syndromes? You remember early menopause is a risk factor for geriatric syndromes and for early onset of geriatric syndromes. So should we start screening women at 45 rather than 50 or 55 as compared to men? Is there an impact on adherence? These symptoms, do they actually impact adherence? We know they impact quality of life. There is no doubt of that. But are women still able to take their tablets? Now, I'm almost done. So, what to do for healthy aging of people with HIV? So, again, there is a lot to do. So there are factors we said that predispose to aging, which are not modifiable. These are age, genetic factors, race, and sex. We cannot change those. Okay, so we need to move on. You are born a female. You're not getting old. You're going to get these diseases. There are modifiable factors that you can have an impact in. They are modifiable factor, but for early life. This is education and also early life nutrition. By the time we see these people when they're older, we can't do anything about those. We can think about those when we take care of our younger people, thinking their nutrition is important for them maybe in 50 years. But when we see these people when they're already old, we cannot act on these factors. So then we should start looking at modifiable factors in middle life. So this we need to start early. We don't have to wait for people to come to us when they are 50 or 60. So when people are in their 30s and 40, we should screen and treat for NCDs because NCDs you have to cancel them on healthy habits, especially physical activity and nutrition. If there is something that works on pretty much everything, cognitive function, physical function, frailty, emotional well-being, quality of life. Some they even say symptoms of menopause is physical activity. So we really need to stress this. Consider hormonal replacement for women. And then in late life, sometimes we see people when they're already in their late life address polypharmacy people should really stop drinking at that age, really stop, because we found it's not published, but for example, we found that people who still drink and are older, they tend to fall and then they tend to break their hips. So it's really because of that. I mean, among other reasons, this is like an immediate threat to your health because when someone that is old falls and break their hip, then really there is a higher increase in mortality. Um, Avoid isolation. Isolation is a risk factor for frailty. So that is something we need to construct around older people, social network. And then I think here, this bar I put here on blue, let's not forget, we have to continue doing what we are doing very well. And we are doing it well, I think, in East Africa, which is the HIV care. Link people early, give them effective art, monitor art toxicity and effectiveness. This we should continue doing, and then we should do a bit more. Uh, so people become too old and we cannot act anymore. Okay, it's my second last slide of some sort. I was asked to talk about this study, although I have to tell you, the results are very promising, but I don't think they're applicable in the short term in our settings. So this was a study that was a phase 3 randomized clinical trial. The good news, if you look at the map, we have really 65% of the population that was non-white, because usually all these trials are done with white people. And then we're like, oh, there is no results for Africa. Let's redo the study. So this is really representative. Women were 30%, so I would say quite representative. And so the intervention was really giving something that can lower low density lipoprotein. And that is really statin therapy. And statin per se can also inhibit the relevant inflammatory pathways. So not only they lower the lipoprotein, but also they act on the inflammation that causes the elevation in the lipoprotein. So in this study, the statin that was given was pitavastatin. Uh, and they looked at the primary outcome. They really looked at a measure at cardiovascular events. If you want to look at details, really go to the paper. Between 40 and 70. The trial was stopped after 5 years because there was efficacy in the intervention group, so they had to give the intervention to the placebo group. Now, in short, what we can see is really that when we look at the first cardiovascular event or death, there really is an increase in the group that is taking placebo as compared to the group that is taking pitavastatin, with a 35% reduction in those who are taking the statins. The diagram down here really just shows that we have to bear in mind that there are some adverse events that were higher in the pitavastatin group, particularly incidence of diabetes and some grade 3 muscles related symptoms. So pitavastatin really lowers the risk of major advanced cardiovascular event. We don't know about other statins, but I really think we should look at other strategies that may lower LDL cholesterol, and that could be like really more scalable in terms of cost, efficacy, and safety in our setting. So in conclusion, HIV infection and female sex are associated with increased NCDs and accelerated aging due to multiple factors such as chronic inflammation and long-term drug exposure. There is really need to describe and project the burden of NCDs and geriatric syndromes for appropriate programming, integration of care, and resource allocations. There are clinical care needs before research even. So for example, training in geriatric medicine. In Uganda, we have 2 geriatricians in the entire country. create awareness among clinicians on the importance of screening, detecting, and treating NCDs early to avoid or delayed frailty and other geriatric syndromes. We addressed the issue of studying more menopause. We need simplified geriatric assessment tools, like self-reported. A typical geriatric assessment takes around 3 hours. This is not feasible in our busy clinics. And definitely there is a lot of research needs. Implementation science for intervention to avoid delay frailty and NCDs. And we also need to study other regimens that are gentle to older people living with HIV. I don't know which one they are. I mean, one of the things people are thinking about is actually dual treatment with the TDF and dolutegravir, leaving out tenofovir. There have been trials in high income settings. But WHO would not implement this because there is no data from Africa. So this is again something we need to think about. Uh, this is all. I'm sorry, it took probably longer than I thought, but I hope. And then there was the interruption with the network. I really need to just acknowledge my funders for my some of the work I present from our court was really funded by EDCTP. These people named here are my trainees, but now are really part of a study team. They are really successfully published, and I hope that they can keep going and try to pursue their research interest in geriatric medicine. I'm going to stop here. Thank you.
Thank you so much, Dr. Barbara, for that excellent talk. So I'll invite my co-panelist, Dr. Anne-Marie. Do you want to take over the Q&A session? So maybe I can start, Dr. Barbara, is like, how is the geriatric care in for people living with HIV in Uganda? So do you have geriatric clinics, and what does the service look like for people living with HIV? And have have geriatric clinics sort of like been incorporated in HIV programming in Uganda?
So unfortunately, absolutely not. But because there is no resources really. So the data I showed to you, it's from Uganda. It's really my cohort, and I think the one of the aim of this cohort was really to first to generate the data to really choose that we need this. Now, of course, there is time to advocate for that. So, what we have done at our centers, but it's a specialized center. So, my center where I work is a specialized center, and also it's not typical in terms of age distribution because we have a lot of older people as compared to young people. So during these studies that we have done in the cohort, we have managed to train. First of all, the trainees they've learned. We have really have self-learned how to do comprehensive geriatric assessment. They've been training each other. First, we trained the PhD, then the PhD student trained the other master students. Then we were able to train nurses. For example, our assessment are performed by nurses because we can't have geriatricians doing that. We don't have geriatricians. So we need to be able to scale this up and do some task shifting. And so the nurses perform the geriatric assessment and then the doctor interprets the results. We were also able to train an additional 2 clinicians to do geriatric assessment. So it's really work in its infancy. But if you look at Western settings, people started talking about this 15 years ago, not long ago. Given that, like in Africa, we start antiretroviral treatment 20 years later than everyone else, and all that. It's like we are at the point where in high income country they were 10 years ago, when they were like, oh my goodness, these people are aging, what do we do? So that's where we are really. So what we are doing now in our clinic is that we have the data is not yet out. We had tried to validate some simplified tools with another small grant I got. They are not perfect. So all the things we see, like for example, frailty, depression, quality of life, we have really tried to see if there are tools that they are mainly self-reported. So anyone can just ask the patients. You don't need a doctor. You can actually just have a volunteer. They are not perfect, but they work. So sensitivity and specificity are not 100%. But at least if we can scale something that is not perfect, but can really help us to screen people who need help. That would be better than trying to do a comprehensive geriatric assessment on everyone, because it's not possible. But I think it's a lot really sensitizing people about seeing all the people with a different lens. Let me tell you, you potentially can look at the way people walk. You look at the gait speed without even measuring it, because that's what we're doing in frailty, and you will know already if they're frail or not. So when you see such old person, what do you do? Even if you cannot do this, the comprehensive geriatric assessment, are you going just to prescribe art and send them away? Or are you going to ask them, maybe ask them more questions about how they feel, for example? Social support and not being isolated improves frailty. So maybe you can just ask this person, what is your social network? Can you ask your relatives to be more around you? Or you can call them up and say, this person needs help. So, I think anything that we can do, even if it is not the complete care, would help actually older people. Thank you.
Thank you so much for that. It's true. And I think even in our setup here in Kenya, we're getting almost half of the people living with HIV visiting clinics are getting to the age where they're 50 and above. And I think what you've told us is very insightful. So I want to go to the Q&A chat, and I'm just looking for the relevant questions. So HIV in an aging population is becoming a reality with every passing day in Kenya, with more people living with HIV living longer than before. NCD burden among geriatric people living with HIV will be an interesting area of differentiated care. So are there communities of practice in Uganda and elsewhere we can learn from or share best practices, lessons learned with? So basically, is there sort of like a meeting, a conference with just HIV and aging within the sub-Saharan African setup that, we could link up with and share best practices? Dr. Barbara?
I don't know if it is my network that is not stable. I couldn't hear you properly, but I think you were talking about um, work that is that's done in Africa and how we can connect. So I have to say again, this I think is another problem I didn't talk about. There is really little work. There is not an aging group, HIV and aging group across sub-Saharan Africa. A lot of, not a lot, but a little research that is done is often driven by external people. So, I mean, there is nothing wrong with that, but maybe people from collaborators that we have in other countries that they will write a grant and then come here and do frailty assessment and so on. So definitely this is one of the greatest need, and I think I suspect this is one of the reason why at least the same interest or they are taking care of the same people can start talking to each other. and see like what else, can we write, we just talked, for example, about all this menopause issue. Yes, I can do it in Uganda, but can we maybe, find like 2, 3 sites in East Africa, write up a grant and say, can we look actually at menopause in Eastern African women living with HIV? So I think this is a lot of work that we need to do as scientists in Africa, is like to try to start connecting each other, because there is really little data. Um, I believe my cohort and my fellowship was one of the first comprehensive work. And we are still analyzing. We have a lot of data. We have not even had time to look at a lot of the things we have collected. So, yeah, again, I hope that one of the outcome of this seminar is not just me coming and present, but maybe someone that can reach out to me after, and we see what can we do really next as African scientists.
So thank you. I'm looking through the questions again. So there's a question on whether the frailty assessment tools have been validated in sub-Saharan Africa, like maybe Fraser, frailty index. Have they been validated?
Okay, so so some of these tools, for example, they have been I don't know if we should go now in the detail on how to measure frailty, because basically there are two different school of thoughts on how to measure frailty. One is the frailty phenotype, which is what we use. And there are those 5 domains I talked about, while the frailty index is more a kind of list of disabilities, includes other things, includes, for example, if you can see well, if you can hear well, it's a long list. And so the more of the more things you have, the more you go down in terms of frailty. So the more frail you are. Now, this is geriatrician cannot agree, and they actually fight on what is the best way. We are not thinking discussing this, but these are the two main. So these are the two gold standards, whichever you want to embrace. These are the gold standards, and so you can't validate them because you don't have nothing else to validate them against. But they do work. That's what we use. For example, for us, we use the frailty phenotype. Now, the issue here is like, can we validate some simplified tools against this standard, gold standard? So, for example, we have done, and that's the thing I was mentioning before. For us, we have used the Frail scale, which is 3 questions. It's all self-reported. So there is, let me say, a fair agreement. And so, but again, that's the problem with the validation study. They were validated in Kampala, Uganda, urban setting. Is it this validation can work in Mali? I don't know. Hopefully, yes, because you are really looking at this domain, you really of like, if people feel tired, if they're losing weight, if they are not, if they don't move. So probably, it will not take tons of these validation studies to say if they work or not. So. Uh, I'm just scrolling down myself on the question and answers. Some are not questions. Thank you for all the say that are saying that the presentation was good. Okay, there is a question of can be done to slow down geriatric syndrome. So this is what I was saying when I was showing the modifiable factors. So it's to address them early when in their 40s, people, they have to start thinking on how they want to age. So they have to start leaving behind bad habits. They have to start having a balanced diet and physical activities. And as clinicians, we need to detect early non-communicable diseases because uh, um, they can they're risk factor for geriatric syndrome. So if anything, at least measure blood pressure of people, make sure that we measure their sugar, their renal function, and so on. What is the commonest cause of death for people living with HIV in the elderly? I don't know. We did so. One thing is that most likely is not HIV related. And the reason why I say that is because 95% of our cohort has viral suppression and they have like CD4 at 700. So the problem, of course, is that I don't know in your setting, but in our setting, sometimes you don't know someone died until someone doesn't show up for many months and then someone makes a phone call and you discover that someone died 6 months ago. And when you try to get the history from the relatives, it's always very confused. It's like, oh, he felt weak and then he died. Like you really cannot. But definitely, my guts is that it's not communicable disease. So that's all I can say. Just a comment, there should be support for women in the menopausal stage. I totally agree. Um Okay, these were the communities of practice. That was I was answering. I don't know the person. There is a comment about genetic sequences could dig deeper into HIV and come out with more information as concerned fragility situation. I'm sorry, I don't understand this question or comment. Um, there is a question about online courses. I can find this information. There are some of my trainees who are doing an online master in geriatric. So I can find out. I think I have two of them. It's 2 years, but it's manageable and it's online. So if you are working, for example, you can continue doing what you.
I think there is another question on the commonest causes of mortality, like sort of like in your cohort. On ART in the aging cohort, what's the commonest cause of mortality? I think we've sort of like addressed most of the questions. I think there was just a question on causes of mortality, the new causes of mortality among an aging cohort.
I'm sorry, I dropped again. I sincerely apologize. I hope you can hear me. I was trying to answer something about menopause. So, as I said, I'm not an expert, but there is a general idea that, again, this ongoing inflammation that happens in people with HIV could somehow interfere with your hormonal balance and cause that menopause to occur early and possibly with more symptoms. As I said, would be very interesting to study again this in African population because you can get rid of you can get rid of some of these confounders like typically like African women don't smoke in both HIV positive and negative so or they are not drug users or they've not been drug users so I think that would be really helpful but it really seems from studying the West that that is the case um I'm trying to go where I left okay I found it. Is aging covered on social insurance in Uganda? In Uganda, there is no social insurance, so there is nothing I can say with that. Should this category of aged clients be separated? Well, I don't know what you mean separated. If they have to go to special clinics, maybe. But remember that soon these people will make up in some centers like half. So I don't know how you're really going to segregate them, because at least in our centers, I think that if we look at over 50, we may have already 3,000. So, oh, separate in terms of care management. You know, it should, because they're becoming so many, it should become in routine. And once, when you are 40, we need to treat your hypertension. If you're a woman and you are 40, we need to start asking you about your menopausal symptoms. You know, I think what you need is a checklist of people when they hit a certain age. We need to start asking them and find out about some of their health issues that right now we're not asking. So I hope it makes sense. So I don't think you need to separate, but you may need to look at really like asking people different things depending on the age they are. Um, in Uganda, HIV service is integrated, so they are not integrated with the other services, but things probably are going to change, especially because of of the stop order and all of that. HIV services are highly funded from out. So I think the next move is going to be, it's not because of stigma or anything, but um, it's because they will need to be integrated in the regular care. So I have to say, in Uganda, um, I'm not saying there is no stigma because there is stigma, but I think probably compared to other countries, I think because the country was hit so badly in the 80s and the 90s, and there was a lot of public talks about HIV, in my opinion, is there is a lot of self-stigma, but that other people stigmatize you because you have HIV is not that so much the case. So anyway, that was just my experience. I've been in Uganda for 20 years, so I mean, I have really a sense of what is going on. Uh, I came here really long ago. Um, so there is something someone asked about menopause and fertility screening are not validated. And okay, so
Dr.
frailty we
Kagima.
can frailty as I explained already. I think people the problem of menopausal screening tools, the symptoms are the symptoms. We can't just create a different list of symptoms because it's cultural sensitive. If someone has hot flashes, they're hot flashes. So that's the problem, And so it's like, how do we actually I mean, I don't know if it is culture sensitive. If we put all women talking about that, maybe they would be happy if we gave them a venue about talking about these things. So it is probably cultural sensitive if you expect women to talk about that out there in public, but maybe in a protected settings that would actually benefit from talking about certain things. Would be part of the healing in a way, I think. And again, it was, if you saw it, it was one of my points. You know, how do we do it? But we can't change the screening tools. You know, if you have if one of the symptoms of menopause is vaginal dryness. I mean, that is it. We may decide not to ask about that, but we may miss someone. Imagine if that is the only symptom of that person. We may actually miss someone that is going through premenopause. So, is the age distribution? I don't know that question. I think, oh, how can we deal with obesity on art and HIV positive? So the question about obesity, I don't know, and I said the reason why I say is don't know because actually there are no studies that show that if you actually order a diet on someone, for example, on the glutathione, they will actually not put on weight. So I mean, it's really hard. I mean, I think part of the weight gain is healthy at the beginning because probably people had lost some weight because of having HIV. But that is another area. Probably we should put it in that list of questions. Can a diet help? Can physical activity help? And actually, there is no answer because some of it is drug induced. So, would diet work on drug induced obesity? We don't know. Julius has worked with dementia and frailty in rural eastern Uganda and is happy to hear about this presentation. Yes, I can share the contact. I think they organize. You can maybe I think maybe I think you can ask the ones who are interested in contacting me. There is no problem. You can ask the organizers. Actually, I mean, if you unfortunately I'm very foundable, you know, like you can just Google up my name and some content is going to appear. Um I don't know the question of Vincent. I don't know, and I don't think it's relevant to this topic. I'm sorry. Um, Yes, so the study findings, yes, they are on open journals. So the one on renal, we have three. The one I've not presented is quality of life. That one I've not presented. Then we have the renal outcomes and the frailty outcomes. Sorry, the comparison, the sex comparison, they are all on open access journals because we like to publish in places where people can actually find really the results. I think that's all. As in questions, and it's also 8:30. I can stay on. It's just that I imagine it's late for everyone.
Yeah, so I think we'll just have like a sort of like 5 minutes, um, sort of like a scenario, Kenyan scenario from Dr. Kagima. She's been doing some work on frailty and aging in older adults living with HIV in Kenyatta National Hospital. Dr. Wanjiko?
Thank you, Barbara, for such a wonderful presentation. Listening to your presentation, I was just thinking we have very similar findings. Most of our population from our work, we were looking at aging in a population that is above 50 years of age. Our data reflects a lot of what you presented. Majority of our patients in terms of comorbidities had hypertension and diabetes. Hypertension was number one, I think, with about 80%, and diabetes second, which is what you've shown, that a lot of these patients have hypertension as a comorbidity. You've also shown that majority of our patients had were in when we looked at frailty, majority of them had pre-frail status measures to actually start working on this area. We also found out that we were able to do a mini-mental cognitive assessment using a mini-mental state examination. And we did find a lot of information that is reflecting your presentation. So listening to you, I was just thinking, this is so similar to what we found. Thank you, Barbara. And I think we will be writing and publishing our works within this year. But I just wanted to say that what you're finding in Uganda is very reflective of what we are finding here in Kenya, in a population that is above 50 years of age, who are in patients living with HIV. Thank you, Wangui.
Thank you so much. And Barbara, I'm actually a pediatrician looking at HIV and aging in perinatally HIV-infected adolescents. And I think I've gotten so much that we need to think through, even in our care of adolescents aging with HIV. So maybe we can have like a parting shot from you, Dr. Barbara. Dr. Barbara, are you here?
Yes, sorry, I was muted.
Yeah, so sort of like a parting shot, or what do you think is one thing you want us to carry from your presentation that we can do today for care of women aging with HIV?
Can you hear me? Yes,
Yes,
okay.
I can. Yes.
So yes, I really think, as I presenting on one of my slides, we really need to redesign, not redesign, but maybe to look at that issue of starting from there, sexual reproductive health, so that we don't leave women, like really, we need to start looking at women in their 40s. We have to start with this menopause issue, but just for many reasons. One is really those years told you, 7 years, women they go through where they're not well, and just to know that we do care can really help. But also, so we are aware also of which women may be at higher risk also. For example, if we have limited resources, or let me say, give enough of aspirin regimens in our clinic. Let's say we have some slots. Maybe we should prioritize women in that had early menopause, because we know they're going to become osteoporotic earlier than others, right? So I really think that's the age where we should start about the well-being of women that are aging. Generally, I don't want to leave out men, but because this talk, is focused on women, I think that tapping in their 40s and redesigning their care would be what I think I would like this to be the pattern shot. The best way of taking care of all the people with HIV is to start taking care of them when they're not yet old. So that would be my parting point. The ones that now are old, we have to deal with them, and of course we need to support them. But can we actually start looking at people before they become older, so that when they become old, they will go through healthy aging? So that for me is the group we need to focus on, is like the people in their 40s.
Great, thank you. Dr. Kagima, any parting shots?
I think I echo Barbara's words that from what our data reflects, it shows a lot of our patients are in the pre-frail state. So I think it makes a lot of sense to start acting when they're about 40 or even younger, so that we can be able to stop and prevent them going into full frailty stage. And also, I had forgotten to mention that we also found out that majority of our patients are also overweight. So this is also a problem here. So I think we can put in a lot of measures, but first we need to educate and sensitize clinicians, starting with clinicians and even the patients themselves about aging and how to assess it and how to prevent it. We need a lot of sensitization in that area. Thank you.
Great. Thank you so much for joining in. I think for me, what I'm learning is that we can't run away from aging, and it's better to start thinking about it earlier rather than later. So educate, educate, educate. Educate the patient, educate the healthcare provider, and start thinking about aging early and anticipate it because it's going to happen. So thank you so much, Dr. Barbara, for the excellent talk. Thank you so much for your insights, Dr. Wanjiko, and thank you for all our participants for joining and making the session very interactive. Thanks and over.
Thank you everyone for your time, and I hope we can have more interactions. Thank you.
Bye-bye.
Bye, thanks. So CPD points will be available through your website. Thanks and over. Maybe even Nelson can talk more about CPD points because I've seen there are lots of questions about that.